Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is
All
missed
right.
by anybody.
So I begin my lecture with welcoming everyone who's there in the class today. Thank you so much for attending the class on a Sunday afternoon, and I'll make sure that your time is well utilized. So at the very outset, let me tell you what exactly is the class about. I'm talking about the GTG, that is Green Top Guidelines, which have been recently published in June 2023, and that changes a little bit scenario about RPL and its screening and its risk profile protocol. And this is one step ahead of the last class that I took. So the last class of RPL, which you will find in my live class recording folder, you will see that it forms the basics of what exactly is recurrent pregnancy loss, and risk factors, investigations, management, lifestyle changes. And the similar thing is there associated in this class as well, but it's totally made from the guidelines. Now, I was trying to tell you the hierarchy of these guidelines, how important these guidelines are. So GTG is the most important guideline, all right? So when it comes to Green Top Guidelines, okay, and when you after that, of course, you have after that you have these nice guidelines. Then you have your FSRH guidelines, and you have your Viva guidelines, that is about HIV and all, and then British recommendations for sexually transmitted disease. So those guidelines, and then you have the scientific impact papers, which are SIPs, and then the TOG articles, which you must have seen me post in your recent advances. The TOG articles are also very, very important because they give you in one go the gist of a particular topic. Okay, so let's begin with the Green Top Guidelines on recurrent pregnancy losses, and this is the latest June 23 edition, so you can easily talk about it in your exams. Now, see, the definitions of RPL we've been speaking about since a long time. So ASRM and ESHRE, they say if you've had 2 recurrent pregnancy losses, that means you're having recurrent pregnancy loss. You can call that patient having recurrent pregnancy losses. That means they have to be, they have to be consecutive. No, they are very, very, very scrupulous regarding their pregnancy losses. But RCOG is a little relaxed, but this is 2011 and this continues here. Still 3 or more first trimester miscarriages. It is still considered. Okay, let me put another this thing to it. Yeah. So they are saying that recurrent miscarriages according to RCOG is 3 or more first trimester miscarriages, and they have to be consecutive. Only then will you call it a recurrent pregnancy loss. But ASRM and ASHRE, they say they can even 2 pregnancy losses, clinically confirmed by histology or ultrasonography, even biochemical or intrauterine of unknown location, they are included. So ASHRE is very, very particular. Even ectopic pregnancy, one ectopic pregnancy and one maybe miscarriage or biochemical pregnancy, and you can say she's having recurrent pregnancy losses. So ASHRE is very, very scrupulous. RCOG gives it a little relaxed look that okay, 3 have to be there and they have to be consecutive. Only then will I call it recurrent. Otherwise, it's not recurrent. She can just have a bad obstetric outcome, and that's it. So by RCOG definition, that is by GTG, this is this definition. Now, you will call it a recurrent pregnancy loss only if there are 3 or more first trimester consecutive miscarriages, right? Now, what about the risk factors? Risk table of the different associated factors which have shown some kind of association. So see, entire table is associated except for non-consanguineous relationship. There is no increased risk of recurrent miscarriage. Otherwise, you see advanced paternal ages, history of previous miscarriages, and one more thing, previous live birth has got no association. Okay, aisa nahi hai, you don't have to require one. Okay, she's had a one live birth, that means she cannot have recurrent pregnancy. These losses are not termed as recurrent. No, they are. There are patients who have received 2 live births and then recurrent pregnancy losses. So we are very scrupulous with them, okay, because they are recurrent pregnancy losses. First of all, she fits into the criteria of recurrent pregnancy losses, isn't it? All right. Then you have black ethnic background, high risk, smoking, high risk, alcohol, high risk, caffeine, high risk, women with BMI, high risk, environmental chemical exposure, dietary intake. Okay, there are limited studies, but there has been some association. Got it? Then our favorite, anti-phospholipid antibodies. I'm going to be speaking at length about it in time to come. So just remember that it has an increased risk for now. Okay. Now, look at this. Lupus anticoagulant. I'm going to write it down, okay? Lupus anticoagulant, okay, was found to have the strongest association. ACL has the second strongest association. Whereas anti-beta-2 glycoprotein antibodies, they show a trend towards the positive association, but it did not have a statistical significance. So you still go ahead and get the lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein antibodies anyways when you're doing a RPL panel, okay? But amongst them, you should know that LA is the most associated, ACL is like second, and then anti-beta-2 is weakly associated. Inherited thrombophilias also show a weak association with recurrent miscarriage. Nevertheless, you can get it done. Then you have parental chromosomal rearrangements. So parental chromosomal, they also have an increased risk. Okay. Chromosomal abnormality, they have a sporadic occurrence. Do you understand the meaning of sporadic, guys? What is the meaning of that? Chromosomal abnormality is the most common cause of sporadic and recurrent miscarriage. Okay. Can I please quickly get an answer as to what do you mean by this? What do you mean by sporadic pregnancy loss and your chromosomal abnormality happens to be one of the most common reasons for sporadic loss of pregnancy? Quickly, guys. Give me a moment. Yes? Any answer? While you counsel a woman in your OPD, I think you give this answer many times, right? No, it's spontaneous. Okay. Yes, we can say spontaneous. Okay. What else? Okay. What I mean by that is, guys, what I mean by that, a sporadic loss, is that I'm not talking about recurrent pregnancy losses. I'm talking about any odd loss at any time, a random. Sporadic means random. It is not having any set pattern. It's not happening after a bad obstetric history or an H-mode pregnancy or a recurrent pregnancy losses and then another loss. It's just random. So random pregnancy loss mostly is a chromosomal abnormality. Yes? Okay. This I'll not speak about. Anatomical factors, very important. Again, it shows increased risk, especially with septate and biconvoid. How many of you knew this before? If I ask you, uterine abnormalities, are they associated? Really, are they associated with recurrent pregnancy losses? If yes, which ones? This question will be asked to you in your Viva. Okay, which uterine abnormalities are mostly associated with recurrent pregnancy losses? So which one are you going to say? You'll say septate and biconvoid. See. Okay, biconvoid is coming in that. Then what about acquired uterine abnormalities? Well, that's uncertain. We do not really know. Okay. Cervical insufficiency, mostly second trimester miscarriage. Yes? Okay. Then what about endocrine? Now here comes your subclinical hypothyroidism, thyroid antibodies, PCOS, prolactin imbalances, all of them have increased risk. Okay? You cannot overlook these. And well-controlled diabetes and thyroid disease, no risk. But if you have thyroid autoantibodies, yes. Subclinical hypothyroidism, yes. PCOS, yes. Luteal phase, no. But prolactin imbalances, yes. So very, very important that you have to see her hormonal profile as well. Do you see this? All this prolactin and subclinical and clinical, I would say, in which you have thyroid antibodies, they are important causes. Then peripheral immune factors, insufficient. Uterine NK cells, insufficient. What about genital tract infections? Insufficient. Okay. Sperm DNA fragmentation, very difficult to assess, has more risk of recurrent miscarriage, and that you can see by semen analysis. DNA fragmentation is there. So based on this, can someone quickly tell me what are the recommended investigations for the recurrent first trimester miscarriages or RPL? I need a proper answer from all of my students who are there. Otherwise, this class is going to end in half an hour because it's a class on the guidelines and not on your topic per se. Otherwise, there's so much to teach you. Okay, so much to teach you. Yes, very good. One is APLA screening. All right, then always start with the history. Okay, what is a BMI? What is a lifestyle? What is her caffeine intake, smoking, alcohol, and what is her age? What is her ethnic background? Didn't we study about all those topics right from the very beginning? So an entire composed history. Then you come to the examination. What about uterine malformations? Correct? Not exactly cervical insufficiency, but yes. And then you come to the investigation. So you have APLA. Yeah, you have very important, a baseline transvaginal ultrasound, HSG if required. Then you have, come on, I'll not speak. Hormonal profile, what will you ask in hormonal profile, Ashwini? Can you be more elaborate? APLA screening, very good. Yes. What all do you have in hormonal profile? Quickly tell me, guys. Okay. TSH, PRL, what else? Not FSH, boy. No. What do you want to have an FSH, LH? See, it's been time that you do not get anything out of FSH and LH, even if you're trying to rule out PCOS. The PCOS is very strict criteria of the Rotterdam criteria, in which biochemical or clinical hirsutism is there, irregular periods is there, and established, an ovulation is there, and of course, ultrasound picture of PCOS is there. Okay. So 2 of these 3 criteria, that means she fits into PCOS, and that is why we do not use FSH-LH anymore. Right. So TSH, everyone is writing TSH and prolactin, and they're missing out a very, very important aspect. What is that? Usha, tell me, what are you missing out? I agree hormonal profile is important, and I do agree TSH and prolactin is important, but still you're missing out on something. And then, of course, we can go to TVS and HSG and stuff. What else? What are we missing, guys? So the Sunday, everyone is lazing around. I just said, okay, agreed. Maybe if it's required, then either you go for a 3D ultrasound. I'll be just discussing about it to you. Better than SIS is a 3D ultrasound. I have done SIS, okay? The septum and everything doesn't really come out so well in that. Diabetes, okay. T3, T4. I'm still not getting the answer. Yes, guys. Give me a minute and I'll get back to you. Let me just drink some water. Yes. Okay. I'm back. So yes, finally, now it has come. The anti-TPO antibodies, guys. I just told you how important they are for you. I think it just went in the last slide, didn't it? See, thyroid autoantibodies are very, very important. They have an increased risk with a recurrent miscarriage. You're saying TSH, but you're not saying thyroid. It's not going to work like that, right? Okay.